Good morning, everybody. Welcome. We're delighted that you're joining us this morning for this session on the IRIS Cost Effectiveness Analysis tool, which we are launching today. We're really delighted that you're here with us today. We're sorry that we had to postpone this session from earlier in the year. And this is a session we've been talking about at least for the best part of a year, Estella and I. So today we have Estella, who is our data scientist who developed the cost effectiveness tool, who is going to walk you through step by step how to use the IRIS cost effectiveness tool. We're also joined by Dr. Claire Ronalds, who has been IRIS clinical lead in Manchester for a number of years and has very recently retired. And Jill Smallwood, who is Chief Exec at Fort Alice in Bolton. And I'm Lucy Downs, IRIS Network Director at IRISi. So in a moment, I will hand over to everyone to introduce each other, to introduce themselves, sorry. And behind the scenes, we also have my colleagues Jaza and Hope, who are there monitoring the chat and sorting out admin for the session. So thank you to Jaza and Hope. So Estella, over to you for a moment to introduce yourselves.
Hi everyone, I think a lot of you will know me in one way or another. I am, as Lucy said, a part-time data scientist at IRISi, and I am an academic health economist, which is how I ended up developing the model a long time ago now, and we've adapted and we're very thrilled to have it shared within our community.
Thanks, Estella. Claire, would you like to introduce yourself?
Hi, I'm Claire Ronalds. I've been in general practice in Manchester for nearly 40 years, and I have retired both in practice and then I've been the IRIS lead since we started in Manchester in 2012, and I've retired from IRIS at the end of August.
Thank you, Claire. And Jill.
Good morning, my name is Jill Smallwood. I work as Chief Executive for Fort Alice in Bolton, so we provide a very large and diverse range of domestic abuse services, including IRIS, across Bolton.
Thank you, Jill. So I'm just going to give a very little bit of context and background to today's session and then run through our plan for this morning. Before I launch into that, I just want to apologise for our first technical hitch of the day, which was not having the waiting room set up. So I'm sorry that you were all immediately pulled into the session rather than being put in a waiting room. So as you will probably be aware, and the cost effectiveness of the IRIS intervention was analysed during the trial between 2007 and 2010, and it was shown to be a cost-effective intervention. However, the trial, of course, is not a real-world setting, and there was a lot of interest as to whether the intervention would also prove to be cost-effective in the real world. So Estella did look at the cost-effectiveness of IRIS in, I think it was 5 real-world sites that have been running for at least a couple of years. And using the same method and the same tool that she developed in order to do that, she has since worked on that tool to make it something a bit more user-friendly that can be used by yourselves in IRIS sites to look at the cost effectiveness of your own IRIS programme in your area. And this is something that funders and commissioners and chief execs have been really interested in and asking us for many years. So we're really excited to be at the point of sharing this with you today. So our plan for the session is that Estella will run through how to use the cost effectiveness tool in a step-by-step way. Then we'll hear from Jill because Bolton, the IRIS programme in Bolton, was one of the areas in which the tool was piloted, who were involved in its development. And also from Claire in Manchester, because Manchester too was one of the pilot sites for the cost effectiveness tool. And then we'll finish the session with a Q&A session. So please do use the Q&A function to submit questions. We won't pause for questions after each speaker. Please do submit your questions through the Q&A function and we'll come to those at the end. If there are more questions than we have time to respond to during the session, then as long as you provide your name and email address, then we'll respond to you afterwards by email. And then we'll wrap up in time for 11:30, and we will have an evaluation form, which I'll put a link for in the chat when we get to that point. Okay, so I think we're there. Over to you, Estella. You're on mute, Estella.
Sorry, guys. So sorry, it took me a bit of time to get the slides up. I think everyone can see my slides now. Are we all good? Okay, so thanks, Lucy, for the introduction. Thanks, Gil and Claire, for being here with me today so that it becomes less technical and more fun for everyone to be involved. So Lucy already actually did part of my presentation, which seems very helpful. But I wanted to talk to you a little bit about the motivation for doing the tool, and then why did we decide to adapt it so that local sites can use it. So back in 2016, when I was still kind of fresh off my PhD in health economics as a young-ish researcher, let's call it like that, because I don't know whether I was young then, but was younger. I was commissioned to do an evaluation by the NIHR, so the National Institute for Health Research, of the IRIS program in commission settings. So IRIS had been evaluated as part of the randomized controlled trial. As we all know, randomized controlled trials are very strict about how they work, which means that sometimes things that come out nice or positive in trials don't actually have the same results in fully implemented settings. And what we wanted to do was see whether the IRIS program, which was a identification and referral program within primary care settings, was effective in the real world. Now, as a health economist, I did what I'm supposed to do and what I do best. I built a Markov model. I'll talk to the model in a minute, which is also known as a transition probability model. So this is this idea that people have different health states and they will move states depending on what the intervention does. Now, I am, and I was at that point an academic. I did the model, I did my results, and I published my results in the BMJ Open. Actually, the cover page of our publication on IRIS is on the screen. Now, at that point, I was doing 5 different evaluations, of which IRIS was only one. And it was at that point that I actually met Claire and Medina and Lucy and some other people. And I kept telling them that the program had outstanding results, results that we don't normally see in health economics. The program came out as cheaper and with better outcomes than the absence of the program. And normally there's always a trade-off. So if something is cheaper, it's worse. If something is better, it's normally more expensive. And then there's a trade-off in that. And then in the IRIS case, it wasn't. It was both cheaper and better. This means that from a NICE recommendation point of view, as a health economist, I had to write in the paper that the recommendation was for the program to be fully implemented across the NHS, because that's what the results of the cost effectiveness did. Now, Medina is here with me, and I know she got really excited at that point, and she told me, oh, how can we do this locally? Because our commissioners will really want to know. Well, I was still pretty much an academic health economist at that point, and I had to turn things that looked quite complicated with multiple tabs into something that people would actually use. And while I get really excited with this, I don't think anyone else does when they look at spreadsheets that look like this. So then we spent a bit of time with another colleague from UCL at the time, who did knowledge exchange, and Medina and myself. So we would adapt the tool so that the tool would be user-friendly for our local sites. Now, the tool continues to be a Markov model. It is as robust as it was in the evaluation that was published at the BMJ, but now has two parts to it, which you can use yourself. And I'll talk to those in a little bit of time. So the tool is the tool itself. It's is a Excel spreadsheet where you fill in bits of data. And I'll talk through those in a minute. But it also comes with a narrative model. And the narrative gives you a little bit of the background to the tool, also how to fill in the data items, and a little bit around the interpretation of your own results. Now, Lucy just asked me this morning, and the tool, because it's user-friendly, it does hide everything that is too techy and that would look overwhelming. It's in there. If someone actually opens my file and breaks my code, they will see it. It's all in there. But the way I did it is I locked it so no one can mess it up and try to break it. And that's kind of the basic idea of what it is. Now, if I can take a bit of time, I would find it really helpful if we go through the tool. So Lucy, I'll stop sharing and then start sharing the tool again. Is that okay? Okay. Right. Okay. So I guess now you're all seeing my Excel spreadsheet, and this is the actual tool. For obvious reasons, these are no one's numbers. This is just mock numbers that we put in so that the tool makes sense. I think the most important part for people to understand is what is a Markov model. So why, when I say it's a transition probability model or Markov model, what is a Markov model? So this is the IRIS Markov model. A Markov model is a model that models health states. Now, as health economists, we really care about improvements in health. To do that, we measure how long people stay on a health state and what's their quality of life at that health state. Now, for IRIS, the model has two parts to it. So the top part is the part where there is no abuse. So this is people who are not exposed to any abuse. And then there's the health state of no abuse. Now, of course, once the bottom, the larger rectangle, is everything that has abuse in it. Now, but within the abuse in it, there is unidentified abuse, and then there's abuse identified that are both seen an educator or an advocate, or about abuse that is not seen an advocate. What IRIS does, it works on these arrows. It works on the arrows of identification, right? So it moves people from the abuse unidentified to the abuse identified, either way. In any case, unfortunately, we all die, so there's an underlying probability of dying from abuse or different from abuse. Of course, the probability of dying from abuse is slightly higher than the probability of dying for other things, but this is the general idea between a Markov model. Now, the tool then has three other tabs. This, which is called data items, which is where you put your data in. So this should be your local data. And Claire, I think you'll do a better job than me because you'll talk through how you did it for Manchester. So we'll do that in a minute. And then once you put it in, there are two result tabs for you. This result tabs that looks quite large and detailed, I'll open it up for you guys to see, has the results for 10-year cohorts. The reason we did 10 years is that the effects of IRIS, because again, health economists worry about time and quality of life. The effects of IRIS are expected to last 10 years, hence why the 10 years. And it has a societal, but we also have a 1 year to make it simple for everyone. So it has a 10 years societal perspective, a 1 year societal perspective, a 10-year NHS perspective, and 1 year NHS perspective. Now, some of you will have heard me say this before. As health economists, we are really worried about the societal perspective. The reason for that is because in a social protection system like the UK, where every social service or every public service comes from the same pot of money, so it comes from taxation, so it's a unique taxation that is distributed everywhere, then we're all paying into the same pot, and it shouldn't make a difference whether this pot is the NHS or this pot is the criminal justice system. So for us, because we're fully taxed social protection system, that's what we as health economists really care about. And in a societal perspective, we have way more than health. So we have cost to primary care, we have cost to ambulance, we have cost to A&E, we have cost to hospital care, but we also have cost to civil justice, cost to criminal justice, cost to the police, cost to housing, cost to social care, and of course, cost to specialized services. All of that is in the societal perspective. Now, we know that some commissioners who are actually here in our audience today care slightly less about this and are more worried about their own budget, so their own NHS budget, their own pot of gold. Now, for that reason, we also did the model with an NHS-only perspective. Now, in that case, we are considering the cost of primary care. We're also considering the cost to A&E and the cost to hospital admission. But then the calculation is only on the NHS pot of gold, which is slightly different. Now, this is all in the long detailed results tab. And we produce a summary tab, which I might make it bigger for you guys, where I talk about incremental cost per woman, budget impact per practice, because I know IRIS is implemented at practice levels. We also calculate budget impact per region, and we give the ISO, which I'll talk through in a bit of time after Claire has done her bit. We have decided to incorporate into the tool a little bit of our interpretation guidance, but I will say this, and I have said this to everyone before, run your own results by me, ask me questions, I'll make your language tight as a health economist so that you can put in your business case at any point in your life, whenever you want. I've done that for some colleagues already. Now, before we move on, I wanted to talk a little bit about the data items. I will not talk about too much of the difficulties with them, because I'll let Claire do that for me, but I'll talk about what we need to make the tool run. So the first thing we need is the local prevalence of domestic violence and abuse. And what we use here, this data that we have here, is the data from the crime survey for England and Wales. This one is actually the 2019 one, which is the most up-to-date published one, and it has calibration on it. So I'll speak a little bit about what calibration is. So there's a problem with the crime survey for England and Wales, and it doesn't measure abuse in older people. So nowadays it goes all the way to 65, but not more. So we, from IRISi, and we, I think, as health economists, believe that's the wrong way to go about this, because if we are seeing people who are older than 65, we have to account for the rate of abuse or the prevalence of abuse for that older population as well. So what I do is that I recalibrate the prevalence of abuse, considering an older population distribution. So it's a little bit of a math that does underlying prevalence in the population times proportion of people who are in older age groups. And this is what we get in terms of rate for an annual rate. Now, there are two bits of information, and I want to talk to this because it will change depending on who your site is. Now, if your site is established for a long time and fully trained, and as Claire will speak to in a minute, she is, for example, all her practices are trained, then the number of women in registered IRA practices and the number of, there are no longer women that aren't in registered practices, because all practices are trained. In that case, we're saying compare yourself to yourself before IRIS. So there are two ways to use the tool. Either if you have practices that aren't trained, then compare IRIS trained to non-IRIS trained. The tool works. But if you are fully trained, and some of our sites are, then compare yourself to yourself, which means your population target will be the same as it is here in the example of the tool. The next bits of data are the easier ones to find, because are the ones you report to IRISi anyway normally. So the number of women referred is the referrals you sent us. We are saying be consistent with your timing. So of course my rate is for a year. My population is in a year. The total number of referrals should be in a year too. Now the number of people for whom there was contact is simply the number of referral minus the no contacts. And then if you are comparing yourself to yourself, this is historical data. So this is data for referrals and no contacts before IRIS. If you're, however, comparing yourself to non-IRIS, so let's say in your area, you have 20 practices that are IRIS trained and 12 that aren't, then this is the comparison. You will have two different population targets, and you will have different numbers here based on how many referrals did you get from non-trained IRIS practices and the no contacts here. Your budget should be a yearly budget. Again, what I'm saying is everything should be in the same time frame. So if you're doing the last fiscal year, it's the last fiscal year. If you're doing the last calendar year, it's the last calendar year. We don't really care so long as you're consistent throughout the tool. Finally, there's this 9, which is the bit that I tell people, this is hard because this is how much time the AE spends making a referral onwards to something else. So for us as economists, it's important that we know how much resource we're using for the service that we do. And if our worker is spending time doing something else as opposed to seeing their patients and their clients, then this is costs that we have to account for. Now, normally sites don't have this measure because they're not actually calculating how long AEs are spending time doing this. If they are, and if they want help with that, talk to me. But if they aren't, that's not a problem. We have the estimates from the trial, which I have inflated to 2019. Again, 2019 here because 2019 is my latest prevalence measure, and I have to use the same in the same costs. So once the new crime survey for England and Wales comes out next year, we'll update that too, and it will be a fully updated spreadsheet for you guys. That's the basics. Now here, the number of practices, and this, I'll let Claire talk a little bit to that, but this is for you to know the size of the impact per practice that you have. So if you, for example, have 20 IRIS trained practices and 12 non-IRIS trained practices, you will be able to differentiate between what difference do you make at a practice level and what difference you make at the region level. Remember? Because I have budget impact per practice and budget impact per region. So if you're an area where IRIS is not fully implemented, these 2 last data items will be important for you to see the difference in there. But that's pretty much the tool. As you can see, if you change a number, it changes the results. You don't need to do anything. Everything is hidden. The calculation happens behind the scenes, but you can change your results. Now, to help you guys fill in the tool and interpret your results, we have prepared a Word document, which is the narrative, which I'll share now. Lucy, tell me off. Am I doing okay for time?
You're fine.
Okay. And this is what the narrative looks like. So have a little bit of an introduction. It will talk to you about how to complete the tool. It will give you where to go for the data for each point. It will also tell you what assumptions to make if you have to make any. And then it will give you at the end an interpretation of the results. But as I said, while I really, really, really want you guys to learn to do this on your own, you're always welcome to send me a paragraph of your takeaway, which I'll review and come back to you. Right, I think that's the tool. Lucy, do you want to invite Gil and Claire to tell her about their experiences?
Thank you. Yes, Estella. So we're going to come first to Jill, who's going to talk through the experiences of her team at Fort Alice on being involved in the pilot for the tool. So thank you, Jill, for joining us this morning, and over to you.
Okay, thanks, Lucy, and thanks, Estella, for that. I think actually you covered off a fair bit of maybe what I was going to input, so I'm going to cut part of mine down if that's okay. But I guess what I want to say is initially when we first came on with the IRIS project, I think one of the things that we were looking at was a reduction maybe in prescriptions, a reduction in appointments for GPs, and we recognised that actually parts of that went maybe the other way, because by getting people into a service, what we started to recognise was that actually people have maybe been deprived of those appointments. So that was possibly the other way and part of the pilot, but being involved in the cost benefit analysis tool has been really helpful. We did hit the issues that you've talked about because obviously we were all fully trained. I think what we learned was, and from discussions that we've had, it's good to also go back and look at the referrals that were maybe coming into services at that time and compare what they look like. And I think that will certainly give us the differences that we need to look at. I suppose one of the things that you talked about is the societal cost was higher, which was a surprise, but it was a good learning curve, and certainly has that impact. And I think it's something that when we're talking to commissioners does need to be in there without a shadow of a doubt. I think some of the things moving forward that we've looked at with the tool, and as I say, we really like it. I think as a tool, you know, we can do a lot with it. I think there's some data that we can start to go back and play around with. It has very much been a good learning curve. And, you know, thanks for the support, because it was really very good. But I think over the last year, obviously, and again, I think it's putting things into context. We've looked at maybe we've had a slight decrease through COVID of referrals coming into the service. So whilst we're comparing ourselves to ourselves, I think as long as we put that contextual evidence around it, that will prove the points that we're kind of looking at. But we are starting to see those increases coming back through in referrals. So I think for us, it's been a really positive experience, and it's something that we'll certainly want to use going forward. We'll obviously have further developments, I'm sure, because I think IRIS plan on keep moving this forwards and further developing. So I think that'll be really good. But basically for us, it's just really reinforcing everything as Estella said, really good tool to use to work on. And some good results. And I know that Claire's done further breakdowns on some of the data that she's had. So I know she's probably going to explain in a little bit more detail how she's pulled some of the figures together by breaking it down differently maybe. So that's me for this morning, very brief, but thanks Estella, because you filled in quite a lot of the gaps that I was going to go through. So are we handing over to Claire next?
We are. Thank you very much, Jill.
Thank you. We started IRIS in Manchester in 2012. It was a public health project to train 16 practices. It's a collaboration between health and MWA, which is the Pancreas Trust Incorporating Manchester Women's Aid, MWA, who deliver the IRIS service. We expanded in 2015 and again in 2016, so that all 96 practices across the city of Manchester could be IRIS trained. So we're funded predominantly by Manchester NHS CCG, with the continuation of the public health, now population health, and part of Manchester City Council funding stream as well, under the auspices of Manchester Health and Social Care Commissioning. We carried out the IRIS CEA in 2017 and again in 2020 using Estella's updated template. This table shows you an overview of our annual referral data for IRIS trained practices compared to non-IRIS trained practices. So it shows you the number of practices, the number of referrals. So for example, in 2014 to 15, we had trained our 16 pilot practices. They made 137 referrals into IRIS. Meanwhile, the 80 non-IRIS trained practices made 6 referrals into DVA agencies. This is despite high level, good quality DVA training being delivered in parallel by the safeguarding team. And it illustrates to you the impact of IRIS, because it's IRIS with its combination of training, really good training, and service delivered into the practices that's made the difference to general practice behaviour. An essential part of completing the CEA is to know what your referral data is from non-IRIS practices. And my thanks go to the IRIS team, the health leads, and the business support officers who collected all this data. Early on, Catherine Cupp was our MWA IRIS lead, and she spent time trawling through the records for the main Manchester Women's Aid, which is the biggest provider in Manchester, and liaising with MARAC and IDVA services to try and identify domestic abuse referrals from general practice. It was quite time consuming. We found that referrals were often labelled health, and she was looking at individual records to identify whether that was from general practice or not. The figures that she came up with, you can see, show 6 referrals made from general practice. into domestic abuse agencies. I'm going to talk through our experience of collecting data for that one-page template that Estella showed you. The first item on the template is prevalence data. We went the first time round to GMP and asked for information on their recorded crime, on the domestic abuse records, and learnt from them that there's a 3-to-1 ratio of DVA incidents reported to police to crime recorded. So there were problems interpreting the data. And because of that uncertainty, the 2017 trial used the 17% domestic abuse prevalence taken from GP waiting room studies. This is much higher than the prevalence of GMP reported crime statistics, and a lower prevalence would of course show a higher benefit. Estella has already said the crime survey of England and Wales is what we used the second time round. We did go back to GMP and we asked the Community Safety Partnership for their data. GMP had a new computer system which was problematic and their data was under recording and unreliable. So with Estella's advice, we used the crime survey of England and Wales. And I just reiterate what she said, up until 2017, the crime survey data excluded respondents older than 59. And I know Estella said that she makes an adjustment for that. So we use a prevalence data of 6.74. And again, I would just say in IRIS, our oldest patient is 88, who after decades of abuse was referred by her GP to IRIS, who made a decision to leave and was helped by IRIS and the safeguarding team to safely leave her husband. What is apparent is that IRIS enables older patients who might not otherwise access domestic abuse services to get help. There was also a time when Professor Warby identified that in some police areas, they were capping the number of incidents reported per patient. I think that's stopped now, and I don't think it applied to Manchester, but it's just to be aware. I want to just say one other thing about the prevalence data. One of the really helpful things that Greater Manchester Police did for us is to plot DVA incidents by ward for the City of Manchester. And then they turned them into heat maps. So that if the map showed deep red, this was an area of high frequency and high severity of domestic abuse. If it was a white area, it was probably a cemetery or maybe a park. We took those maps, they were absolutely astounding, and we took those maps to Clinical One training for every single practice. And I think for all of us clinicians who've kind of come to understand domestic abuse as a health problem, it made visible what is an epidemic that we hadn't known about before. So really important for us, and working with the police was really, really helpful. And of course, what's police reported domestic abuse is just the tip of an iceberg. The next item on the template is the number of women registered with GP practices. So in 2017, we used data from NHS Digital. They are really helpful. The data is given in 5-year bands or 1-year bands. You need to know the individual code for each general practice and for all the practices in your area. However, it's a slog to collect that data. So in 2020, I learned a bit more, and we asked the CCG for help. Whether you ask primary care commissioning, or you ask your medical director, or you ask quality and improvement, somebody in that organisation has the expertise and the ability to extract that data much quicker than we could do it. And we got information back on the practice population for women aged 16 and over within a few days. So thank you to them. I know they've been really busy during COVID as well. And our total population for women had increased by 18,000 over the city. So the next item is the number of women referred into IRIS This is just a reminder to exclude men if your service, as ours does, takes male patients. So you're looking at practices and looking at they have to be fully IRIS trained. You're looking at referrals made over a 12-month period. In 2017, our analysis was from January to December. That actually crosses 2 financial years. And in 2020 last year, we used the financial year, which is much simpler. So from April to March 31st, 2019 to 2020. Now you're only looking at new referrals coming into the service. So anybody who is re-referred by the practice or who self-refers back in are excluded from the analysis. And we did not include those who were already in service at the beginning of the year. So it isn't the full workload of the service, it's simply looking at the new referrals. So you're collecting data for a 12-month period, which is all standard IRIS data, and that's quite straightforward. The second figure is the number of women with whom contact was made. Now, our no contact rates, and I'm sure it's true for everybody, vary annually from about 16, 17, 18% up to the highest 24%. So you need to know what your no contact rate is. About 18% is in line with what IRISi is nationally. So the year that we looked at, 2019 to 20, we had 964 referrals into IRIS. If you think back to our pre-IRIS data, you're looking at 6 referrals across the city of 96 practices. We work really hard in training to emphasize the need for correct contact details when we're training the practices and doing update training. But in that year, 2019 to 20, our no contact rate was 24%. It's gone back to 17% last year, so it's improved again. For the number of women referred to an advocate, non-IRIS trained practices, that's looking back, as the table showed, to the original data, which was 6 per year, roughly 6, as you saw on the table, it was 4 or 5 for each of the first 3 years, but less than 10 per year always. The next item on the template is looking at budget. If we just go on to the next slide. As I said, most of our funding is from Manchester CCG with a stream from population health. And we include both those elements of budget, and it's the total budget, not what was spent, but actually what the budget is for the IRIS programme in our area. The item that we have most problems with is the cost of onward referral. So at the beginning, Catherine Cutler, as I said, in the Health Lead, tried to track time spent by the IRIS advocate educators on each of the various activities to calculate contact time. It proved really hard to do, too time consuming, and when, as the AEs are incredibly busy, it just wasn't reliable data. So back to Estella, always really helpful at what to do. And we use the IRISi trial data, which has been updated to the 2019 inflation rates. Looking at the number of practices, the next element in the template, we updated in the CEA in 2020, and we used the number of practices. We're now down to 85 practices. Our population is greater, but our practices have amalgamated from 96 to 85. So we used 85 because that's the amalgamated number. And actually we used 88 as the number without IRIS. That was what we had at the beginning of the year. When we did the 2017 analysis, we did January to December 2016, and we had 45 practices who were IRIS trained. It's entirely coincidental, and 45 practices not IRIS trained. Again, less than 96 because of amalgamations. And we followed them for a year, but because we were still training, for some of those 45 non-IRIS practices who came into training, we excluded the referrals that they made to IRIS during that year from the analysis. So it's kind of holding a steady state at 45 trained and 45 non-trained. as Estella said, it's really useful to know that you can put the data into the template. It's all protected, so you're not going to delete anything essential, and then you can play around with your figures. The next slide shows you our results. We found that MWA IRIS costs the NHS less than 10p per woman aged 16 or over registered with the Manchester General Practice. It saves societally over £40 per woman. And if you combine the two, it saves over £40 per woman per year. I think our results are an underestimate of the true value of IRIS. I think IRIS is cost saving to the NHS, because although the costs about domestic abuse have now been increased to include mental health, it doesn't include children, the impact on children, safeguarding children. It doesn't include the wider health benefits. It doesn't include men. It provides value for money in commissioning IRIS. We were asked to present our data to our steering group and went back to Estella again. I've just said, as she said, keep sending her your queries. Really helpfully gave us some slides to share with our steering group to explain about how you make these cost benefit decisions. But really, it's quite simple in its basic form, which is it costs less and it gives you better outcomes. So it saves Manchester at least £40 per woman per year. And if you look at our data in 2019 to 20, we had 964 referrals into IRIS compared to 6 before IRIS existed. So effectively, it should be the dominant strategy, and it should be the dominant strategy across all general practice. I'm going to ask Estella to explain to you the slides that she gave us to share. The message from our commissioners is to keep it simple, and just keep in mind what good value it is. Over to you, Estella.
Thanks, Claire. Thanks, Claire. So I'll try to keep this brief, and I don't want to be kind of very technical, but as Claire was saying, nowadays anything that's recommended by NICE has to have some form of what they call health technology assessment or a health economics evaluation to it. And if we were to just plot very simply a matrix where in one end we have costs, the other end we have effects, that's why it's a cost effectiveness tool, then costs can be either higher or lower, and the effects or the benefits, the effect of the intervention, can be either better or worse. Now, it's a little bit of a no-brainer that if something is more expensive and worse, it should not be implemented. You know, we should just reject. It's not good spending of money. If something is, however, cheaper and worse, there might be a trade-off, because, as we know, we have a total tax budget that we need to make fit. This, however, is very uncommon. We don't really deal with cheaper and worse. Normally, in the world of economic evaluation, which is what I do for a living, we are in these two areas here. So things can either be a bit more expensive or more expensive and better. And we would all know that. It's a little bit like the COVID jab, right? It's a little bit more expensive, but improves health outcomes. So it's in this yellow area. Or something can have the best of both worlds. It's better, has better outcomes, and it's cheaper. And if something is better and cheaper, then again, it's a no-brainer. It should be widely adopted. And Claire's point is that this is where, and this in health economics, we call this a dominant strategy, because it's obviously the best of both worlds. And Claire's point is that IRIS is actually here. So the IRIS program is both cheaper in costs, which is why we see societal savings, but it also improves the quality of life of women. And what I just want to point is that while the model does quality of life of women, it's not only, it measures across every single woman. So although not all women are subject to abuse, we're trying to average it out. So while it may look very small per individual woman, we're looking at individual women registered at GP practices age 16 plus. So if we did this math for the women affected by abuse alone, the size of the effect would be really, really, really big. Now, I just wanted to make it clear that very often we are actually in this quadrant here where things are a little bit more expensive, but also better. And NICE says these things have to be taken into consideration and have to be commissioned. The flu jab is an example of one, for example. And in that case, if something is more expensive and better, it depends on how much the healthcare system is willing or able to pay for the additional benefit. So there is a rule in the UK, and the rule is set up by NICE, not by us. So NICE says that anything that has a cost per QALY of under £20,000 per person per year should be approved. And this is really important for IRIS too, because I want to make it very clear that even when the IRIS program isn't cost saving, it is highly cost effective. And I always give the flu jab as an example. The IRIS program nationally is at least 4.8 times more cost effective than the flu jab. So when you're interpreting your results and when you're making your decision, I mean, this is one of the reasons I like being an economist. I have to make the calculation, but I don't actually have to make the decision. I let NICE do the decision for me. And NICE tells me anything £20,000 per person or under, good value for money. So this is the takeaway that I would like us to kind of, and if we can, raise a bit more questions in the discussion, because that's really important that, you know, commissioners understand that. They commission things which are cost effective. They don't necessarily need to be cost saving. And IRIS is societally cost saving, but it's also very cost effective from an NHS perspective, which I really wanted to finish off on. Lucy, just before I open us to the Q&As, because I know that Claire talked a little bit about the difficulty getting the NHS digital data, I want to show you, everyone, where it is and what you need to do. I know it's a bit of manual work, like Claire said, but I just wanted to show that it's not impossible and it takes a little bit of filtering. So if it's okay with everyone, I'll stop sharing the slides and show that in a minute. Okay, so right. So as now you're seeing now, I have a page on the internet, right? So this is the NHS digital internet page. If you look, it's nhsdigital.nhs.uk. If you type on Google, patients registered at GP practices, this is the page that will come up. This page is really, yes, Lucy.
I was just going to say I can put the link in the chat if that would perhaps be helpful for people.
So on this page is updated every month. They recalculate the number of patients registered at GP practices on a monthly basis. And as Claire says, it's a bit unwieldy. It's not very easy to use, although they're trying to improve and they have created something, which is a tool which I'll show in a minute. But in here, you can download your data into a spreadsheet. And as you can see, it does now break by single year of age, which is what Claire was saying. It breaks by GP practice, commissioning regions, STPs, CCGs, and PCNs. So you can filter it that way. And in our case, I would recommend, if you want to go this route, you download this file, patients registered at GP practice females. I will open the spreadsheet so that you see, this is what the actual spreadsheet looks like. Oh, let me make it bigger for everyone. And on the spreadsheet, as Claire said, you can filter. There are two ways you can filter. You can either filter by actual practice code, or you can filter it by postcode. So if you know the postcodes of the practices you've trained, so this is the practice code, which you can open and you will find it, or you can filter them by postcode now. And as you can see, you have all ages, so you can exclude 0 to 15, the number of patients, and then you just add them up. It's a bit of work, I get it, but still possible to do if you don't have close buddies at the CCG like Claire does. So just so that everyone sees. I also wanted you to see the actual tool that the NHS is doing now. So this is how they are now trying to portray data from GP registered patients. As you're saying, it's now a map. You can click female or male. You can filter them by here as well. You can filter by CCG group. You can filter by practice, and it would also display it to you. And in this filter by practice, as you can see, you have the practice code, but you also have the practice name. I know Caroline Murphy is here with us today, and she'll say, well, the difficulty with the interactive tool is that they are not breaking the age correctly. They break the age in 10-year gaps, which means that we're losing the people from 16 to 19 a little bit in here. And for that, we might need the spreadsheets. But I just wanted to show to everyone, the data is there. Even if it takes a little bit of muscle work, it's there, it's online, we can get it. And we can help you get it if you need to. Okay. I'm done with the
Great. Thank you, Estella, and thank you, Claire and Jill. So we're going to open it up for the Q&A session now. So some of you have already put some questions in the Q&A. Please do, if you have any further questions, use that function to submit them now. We've got some time to respond to those. So a practical question first off, this is for Estella and Claire. Will the slides be shared after the event?
I'm happy to. Claire?
You're on mute, Claire.
Apologies. Yes, I might just take out and just show a couple of lines from the overview table for IRIS, but yes.
Thank you, Claire. I also have a question about finding equivalent patient data for Wales and Northern Ireland. Now, Estella, you might be best placed to answer this, but I know that it is possible to get the data, but just not from the same source.
So Wales is actually the same source, because NHS England and Wales are actually one institution. So Wales is covered. It's covered on the crime survey, because the crime survey is for England and Wales. It's also covered on the NHS digital sharing. You can find Wales in there. Northern Ireland is a different data source. I have the Northern Irish data sources as well. If people want them, I'm more than happy to share the links to those.
Brilliant. Thank you, Estella. And a question, I think, so this one is for Estella, I think. It's about when to run the cost effectiveness analysis. So I think this is coming from someone in a newer site. Is there a point at which it's going to become more useful to run it, or doesn't it make any difference?
So I think there are two answers to this. The tool actually works at any point for 1 year, which means you don't have to wait until you're a fully established site like Manchester has. The issue with running it before what we're saying kind of year 2 is the setup costs. So we know that IRIS is much more costly to start with. So that, you know, because IRIS in year 1 and sometimes year 1 and 2 is a bit more expensive, your results will become a little worse. It doesn't mean the tool doesn't work. It doesn't mean it's not an actual tool that gives you the de facto results. But obviously, if you are a more established site, then your setup costs will then have gone down, and then you will have a more realistic overview and picture of your way forward, which is really what we want with a CEA tool, because we want to prove to commissioners this is good value for money, this is worth investing and continuing to invest, as opposed to oh, this was worth last year. So I think the tool has to be, is a little bit like driving, right? So you have to have your eye on the back mirror, but when you're running the tool with a year-old data, which means that what you want to portray is that this will become even better as time goes on. And I will reinforce, Claire, I'll move back to you, what Claire said. The model as designed now only accounts for benefits for women, which means that alone means is an underestimate. We're not counting for benefits for children, also not accounting for benefits for male patients. We are, however, I will say, so everyone is clear, developing those tools within a different type of setting for another trial, which is called ReProvide, where also children and men are accounted for. However, the model will come up as an academic model next year, which means the tool will probably only be available in 2023. That accounts for all three.
Thank you, Estella.
Claire.
Can I just add to that? The time to do it is when you're going for investment review, which in Manchester was either every year or 3 yearly. And it's a really important piece of information for the commissioners. And our steering group chair would say, this information enables them to know that they are making a really good reinvestment and that they are investing money to save money. And that was quite important in our 3 yearly investment review.
Thank you, Claire. That brings on actually to another question, which really I think is both to you and to Jill. Now that you can demonstrate cost effectiveness, and do you think this has supported sustainability and commitment from commissioners in your area? So Claire, it sounds like it has been helpful from your perspective on that. Jill, how about in Bolton?
I think for us, it's maybe more of the start of a journey, but yes, I think it will be really helpful. Yeah.
Thank you.
Yeah. Lucy, can I just ask, there's a question saying that they missed what I was saying about the funding streams. So what I was saying in Manchester is that we've started as a public health pilot, but then when we expanded twice in 2015 and 2016, it's funded by the CCG. And so our main funding stream is from NHS Manchester, but we have a continuation of what is now Population Health Department of the City Council. So we have a secondary funding stream from them, just to answer that query. But I think it's been really important. I did ask both sets of commissioners, and the answer, it just is that it's giving you information, or giving them information which enables them to be confident in reinvesting the money, that it's the dominant strategy and worth doing.
Thank you, Claire. I've got a further question, and this one is for Estella, I think, really. Can this tool be used? You've mentioned already that men and children, and how the work on ReProvide will look at cost effectiveness for that expanded IRIS model. What about for the advice programme? There's quite a lot of interest at the moment in the advice programme. Can this be applied in the same way for advice? Can it be used for advice?
So I think you will be happy to know that I have recently finished a piece of research in my academic post where I actually look into the cost of sexual violence on its own as opposed to DV, which means that once I publish from it, because I have to do that first, we will be able to adapt a tool that will then be suitable for advice in terms of sexual violence as well. I have a slight less clear idea whether we'll do a joint tool that addresses both DV and SV, because they have obviously different sets of costing, but also different sets of funding streams. There are two things I want to highlight, though, from what Claire said. And I think I made it very clear that as an economist, I'm more worried about the societal impact than I am about the NHS impact. But because I know that the tool is actually designed for sites to use in their business cases, in their recommissioning, in their steering groups, you will know how to pitch to your own population and what's more important to your audience. And for example, if you're not being completely funded by the NHS, let's say you might be funded by, some other types of police funding streams, you might, then maybe you highlight a bit more of the societal impact in there because that's relevant. If you're, however, fully funded by the NHS, then yes, stick to your NHS analysis. You might have your own view. I also just wanted to say that I don't think people quite understand how amazing the results that Claire showed, for example, are, because she's saying it's £40 cost societal savings, not per woman referred, it's per woman registered. So when you do the maths and how many women are registered at GP practices in Manchester, that becomes really, really large. I mean, you get the total footprint of Manchester, multiply it by 40, and this is the societal saving IRIS is doing in her region. And I think this will be true for every single site, even if they don't get to the £40 societal savings, even if they're saving £2, it's £2 per woman registered. It's not £2 per woman referred, which means the actual scope of IRIS is really, really large. And you have to try and convey this information to your commissioner, because I know, because that's what I do for a living. I do evaluation of interventions around there, that out of every single intervention I've evaluated in my life so far, and I have done many, I have never come across a result of this magnitude.
Thank you, Estella. That's really helpful explanation. Thank you. Got a couple of other questions here, and I think this is probably one for everyone here on this panel. Is there a danger that some commissioners and funders might use arguments about cost effectiveness to want to set the budget for IRIS quite low? Is this something, Claire, Jill, was there ever any, and this is quite a difficult question in some ways, but I think it's like, I can imagine that it's not just the one person who might be wondering this. So perhaps if I could come to you first, Claire.
No, I think the IRIS budget has been set by our hoped for workload and then the team that we need in order to deliver that. So delivering both the training and then the service. If you look at 2019 to 20, going from up to 964 referrals, new referrals, it's not the full caseload. I would argue that team is working above its capacity, and we actually need to go back for more funding if it continued. I should just say, and one of the things about kind of publishing the data about the caveat for 20 to 21 is referrals dropped to 741, and I didn't say that's in the context of COVID, when for the first 3 months practices were effectively closed, and IRIS did brilliantly well, IRIS nationally, in setting up online training about how to ask during telephone consultations, and then you see the referrals pick up again. But those first, the figures are lower because of the first 3 months. But even so, it's still working at greater capacity than it had originally been developed for. So it's not that the cost effectiveness should set the budget, but it's a demonstration about how effectively that budget is being used. Over to you, Jill.
I would agree, Claire, and I guess one of the things that I think is always positive is, we're in constant discussions with commissioners on the number of referrals that are coming in, the workloads that are coming in. Obviously, this is something in addition, but I think equally the fact that IRIS set nationally the salaries for practitioners gives us really a balance right across the piece. So I would agree that I don't think it will be that this will set a budget at all. I think it's very real, and I think it's about having those very congruent conversations with commissioners and working with them. Our commissions in Bolton are fabulous. We're really, really lucky working with them. So no, I don't think it should or would.
Thank you, Jill. And Estella, have you got anything to add to that one, or is it kind of outside of what?
No, I do. I do. In the world of evaluation, and this is something that I try to convey, and one of the motivations for us to build this tool is that commissioners are in a tight spot. They have a budget which is, you know, tighter and tighter, and they have to prioritize. And so if you can put IRIS in perspective, you know, compare it to other interventions that they have to commission. So they have to commission HIV screening. HIV screening is actually not even cost effective, and they commission that. So it goes above the £20,000 threshold. The cost is actually quite high. Still, they commission that. Compare it to the flu jab, which is also commissioned on a yearly or on a 3-yearly basis. IRIS is, you know, 3, 4, 5 times more cost effective than that. And it's conveying that, you know, I think, and I've said this before, commissioners all understand they have a moral duty to do this, is going beyond that and showing that actually, like Claire said, is good value for money. You're putting a little bit now to save down the line, and that sticks and that makes sense. And that is something that then becomes a stronger case. And by being the tool is helpful because you're not using, you know, an academic paper that was published at the BMJ or something. You're using your own numbers, you're using your own budget, you're using your own, and that is then a compelling argument for your own commissioners, because it's not that you're saying, you know, this people did that a long time ago. You're saying now, with the data we have now, that's what it shows.
Thank you, Estella. Another question. So I guess this one probably is also for you, Estella. We've really struggled with recruitment and staffing in our organisation recently, and had a period for several months when no one was actually delivering the IRIS programme. Will this affect what the model shows us or what we should put in?
So I think it will affect the number of referrals. So if you remember the data items that we had, it will certainly affect the referrals coming in and the services you provide, and the number of no contacts. So obviously, if you had a disruption in service, which is effectively what you're talking about, your results will be slightly worse. It doesn't mean the tool doesn't work. It doesn't mean you can't still show your tool. It just means that you, when you explain it and when you create your narrative around your results, you will have to explain that too, because you will have to explain a little bit like Claire was just saying now that, you know, well, last year we had 941 referrals, or 900 something, and this year we have 741, but effectively we were closed for 3 months. So it's not that there was a quarter drop in referrals. It was effectively, there was 3 months that nothing was happening anywhere. So it wasn't possible. And that puts things into perspective. And I think people understand that once you explain it. So I don't think it stops or prevents you from using the model. I think what will happen is that it will change your results because you had a period of disruption.
Thank you, Estella. That's really helpful. And I think we're on to the final question. So this is a practical one. When will IRISi be sharing the tool and the narrative or user guide with us? And Estella, I'm sorry, I think this one is for you as well.
So I am actually super happy for it to go by the end of, I don't know, I think we'll need Jeza to tell me when she will be able to send to the whole of the network, but I'm sure next week, if the latest. We are asking you guys that have a little bit of a play. I mean, I know Claire spent a bit of time playing with that. I know that Vicky in Bolton, when we were doing it, also did. I know that some other sites that tested the tool for us also did. Spent a bit of a time. Your regional managers are actually here with us because they are also kind of trying to learn how this works. Ask them questions, ask IRISi questions, ask me questions. Try to play with it and then see how you get on. We're very keen that it becomes almost like what comes up with the IRIS package. So, you know, the IRISi package of support and the relationship that's established between IRISi and the services now has one more tool that should be helpful for everyone. And this is what we want it to go. And we know that it's quite timely for you to take it at this side of Christmas, because you can start playing. I know some of you will need to build business cases in the early parts of next year. So that should be a tool that you can have at your disposal by then.
Thank you, Estella. We've actually got one more question. I've just realised, sorry, I missed this one earlier, and I think we do have time to answer it. It links back with the earlier question in some ways about might commissioners or funders use arguments about cost effectiveness to try and limit the budget. And the question is about commissioners being interested in seeing more with less. So kind of squeezing the IRIS service and wanting the same size advocate educator team to work with more practices and more patient population per advocate educator. Perhaps if I come first to Claire and Jill on this, as people representing real world IRIS sites, is this something that you have experienced, or is there anything you would say in response to this question or this challenge that might be faced?
Claire, I'm happy to pick that up because mine's probably quite a simple answer. No, in essence, I think the steering group, always recognises, and we have some really healthy debates and discussions about what that workload looks like, what's coming through. And again, it's about for us always making sure that we're able to put the contents, the evaluation around that. So for us, our commissioners are always open to, and I can't say that it's been a squeeze at all. We've been very real about what we're dealing with, and we've been very real about when, the figures drop, what we were doing to increase those figures and to be able to make sure that IRIS was still working very effectively in Bolton. So for us, I can't say it has been. Claire, I don't know if you want
That's
to
really reassuring.
Can you just repeat the question, Lucy, for me?
Yeah, sorry, well, I kind of paraphrased it from what was written. So what was written was, I think it's more about commissioners trying to squeeze more out of the service, such as wanting AEs to work with more practices and increasing the patient population worked with.
Yeah. I don't think there's any doubt that commissioners want to squeeze as much as they can and get that value for money, and they have to make very hard decisions. And indeed, I've been told before now, if we commission this, what is it that we don't commission? What are we giving up in order to commission the IRIS service? And so those are the kind of real life difficult decisions that they've got to make. I think because IRIS has made people aware of the health impacts, what a health problem it is, which I think before we started, I think personally, wasn't aware of just how much of a health problem domestic abuse is. And it's that changing recognition that's changed, I think in Manchester, changed in the last decade, huge understanding. So they have difficult decisions to make. They will try and get as much as they can out of the service. I think we have to be clear about what we can deliver safely and effectively. And this information is really important, because if we can go on showing the economic advantages of doing it, that's also an important factor in their decision making. I think our steering group chair would also say that the diversity and equality assessment that was very detailed, that went into the last investment review, is also an important factor. Because that's also kind of one of the pieces of work that IRIS does. It's to balance out accessibility, if you like. So of course they'll try and get as much as they can, but the cost effectiveness template just enables you to give such good evidence about the value that IRIS offers. And we have gone back 3 times now to get the service expanded as we have grown.
Thank you, Claire. And it has, hasn't it? It has expanded at those different stages. Yes. Yes, thank you. Okay, well, I think we have got through all of the questions. So thank you all very much for joining us today. Thank you to our panel. Thank you to Claire in Manchester and Jill in Bolton. Especially thank you to Estella. I'm very glad that you were well enough to join us today, and that it wasn't me trying to explain the tool to you all. And thank you also to behind the scenes Jayza and Hope, who have been sorting out the tech and the admin for us. Jayza is going to pop an evaluation form link in the chat for you all, so please do take a couple of minutes to fill that in. We have been considering that this potentially might be the first of a series of semi-regular, maybe a couple of times a year, sessions that are aimed at IRIS service managers, chief execs at IRIS partner organisations, and commissioners and funders of the IRIS programme. So we're really interested to hear from you through the evaluation form as to whether this session was useful, and if there are any other topics that you would be interested in hearing more about. So we welcome your feedback. And many thanks for your time today. It's great that you could all join us, and the session will be available. We have recorded it for any of your colleagues who have missed it but would like to see it. So I think that's it from me. Thank you again, and this is the first time I've said this year. Happy Christmas to you all.
Thanks, everyone. Thanks for joining.
Thank you very much for being here. Bye.
Thanks, bye.
Bye.